The Basic Metabolic Panel, or the BMP, is arguably the most common lab that you're going to get at your physician's office. But there seems like there's a lot on there, but it's really not that bad. Today we're going to talk all about the BMP, how to interpret it, and how to interpret it in the athletic context. Let's get started. First, let's talk about why do we care about this, right? So this is a super commonly ordered test. As I mentioned before, maybe the most common thing because it's super prevalent. It is used for screening, monitoring, and diagnosing various conditions. It's also used to monitor the effectiveness of treatments or conditions, things like high blood pressure, we're looking at it, kidney disease, certain medications, we're gonna look at the side effects. So really, this is a big one. We are ordering this for so many things. We do it for monitoring medications. We do it for so many things. So very common. Odds are if you've been to a doctor's office and gotten lab work, you've probably gotten a BMP. And so we're gonna break it down here and show the components of it first. So the components here is kind of what we're looking at, the Basic Metabolic Panel. This is kind of just a generic one here. So it even says Basic Metabolic Panel, there it is. As you can see, like most lab results, we have some sort of results. So this is what you personally had. So on the video version here, I'm kind of pointing to a column, and then there's usually the units here, and then there's a reference range. So reference range is pretty much what we expect to see, for a general quote unquote normal person. That's what we're looking at. Here we can see there's glucose, so looking at your blood sugar. Then there's a couple things called the BUN and creatinine. We'll talk more about those. Those are technically kidney markers. Then we have a couple computations here. We have EGFR and EGFR. We have those who are non-African American, African American. Sometimes those are divided up in different calculations based off of different calculations based on race. And then we have this BUN creatinine ratio, which is once again looking at kidney markers. And then we also have electrolytes like sodium, potassium, chloride, carbon dioxide, and then calcium as well. So these are the main components of the BMP. That's a 30,000 foot view. We're going to dive into what each one of those means, but those are the main components of this Basic Metabolic Panel. And some of them may have the EGFR listed right away. Some of them might not. Some might not have the ratios. That's okay. But going in there, let's dive into what that actually means. So first and foremost, glucose. Obviously, most people are familiar with what glucose is, right? Or sugar. So glucose is blood sugar. It's a critical indicator of how much glucose is going on in the body, which can be indicator for diabetes, and it can be very helpful as well. But it's most helpful when we're fasting. So if you don't get this fasting, if you're saying, hey, I've got this and I just ate, then we don't know necessarily what to make of it. That's not the reason you order a BME typically, although you can, because let's think about this. You can actually diagnose diabetes with fasting glucoses, right? So the other day, literally in my clinic, someone had 2 fasting BMPs with elevated blood sugars above 126. So we got to make the diagnosis of diabetes. And so you can do it for that. That's typically not the lone reason for it, but it's very helpful when it's fasting. And typically we want to see that between 70 and 99, and less than 100 is ideal. That's, once we're getting up to 100, that's more of the pre-diabetes. And if we get in there, that's, we don't want to be talking about it. We obviously ideal, the lower is probably better to an extent, but we don't get too low. Just had a patient in the hospital today who had a blood sugar of 25. And that's why I get admitted to see me, is because that is very low, and that can lead to issues. So this is kind of just a nice barometer of, hey, what is going on with glucose? And we're not necessarily making changes all the time based off of this, but it's important to know as well. And then next, move on to the BUN or creatinine. So BUN is blood urea nitrogen, and blood urea nitrogen, essentially this is indicative of how much urea nitrogen or a waste product is in the bloodstream. So usually it's broken down by the liver, and that's how we get this BUN. So we kind of have this waste product. Normal range there is about 7 to 20. And then we have creatinine as well. So not to be confused with creatine, right? So we'll talk a little more about that later, but creatine is the supplement you take. Creatinine is the lab value that we can look at. So not to confuse that. Creatinine is a waste product filtered by the kidneys, made by breaking down muscle and protein. And you can see elevated levels with kidney dysfunction. And you also have this ratio we talked about, right? The BUN to creatinine ratio that we saw up there can provide additional clues about underlying conditions, things we can kind of determine between what we call pre-renal and post-renal or intrarenal causes of kidney dysfunction. So if you have an acute kidney injury, you can sometimes look at that and say, hey, that may point towards pre-renal, meaning maybe dehydration, something like that. Regardless, if your BUN to creatinine ratio is very elevated, you shouldn't be interpreting any of these on your own. This is just to kind of help you understand. This is never to say, hey, you should take this as advice, but just understanding. And normal ranges for the BUN is typically around 7 to 20 milligrams per deciliter, and creatinine is about 0.6 to 1.2 milligrams per deciliter, and that is going to depend on also where you get that reference range. Some people stop at 1.1, others I've seen up to 1.3. As we mentioned, most labs kind of variable there, but that's the general range, about 0.6 to 1.2. And then we also have the glomerular filtration rate, which this is a calculation to determine how well the kidneys are filtering things. This calculation is based on age, creatinine, sex, and race. And so we expect it to be way higher in younger and healthy people. However, anything less than 60 usually requires a workup and could be a sign for something called chronic kidney disease. And so if you're less than 60, you will want to get it checked out, and you should be, higher than younger you are. And we'll talk more about those, kind of how this is abnormal in a bit and what to think about that. Next, moving on to calcium. Calcium is super important. We hear about it all the time for bone health, but it's really important for muscle contractions, nerve signaling, stabilizing the cells, blood clotting, lots of different things that it is important for. Also can help assess the parathyroid gland function. And medications, diuretic medications, steroids can all affect calcium. And our normal range is about 8.5 to 10.2. Next, moving on to what we call our electrolytes, right? You can't go on today to any sort of person on YouTube or marketing and they're talking with I need my electrolyte drink, right? I'm replacing my electrolytes. That's probably a whole other podcast, whether that's actually worth it or not. But today we're going to talk about what those electrolytes actually are and what they mean by that. First, we have sodium. So sodium is super important because it maintains the fluid balance for our body and is crucial for nerve and muscle function. So a lot of times if your sodium's off, we don't love that. The normal range is about 135 to about 145. And both hypernatremia and hyponatremia are problematic. So hyper is when you have too much, hypo is when you're too low and have too little. And they can have serious complications, including confusion, seizures, and a coma. So we care about this. Also this week, as in the hospital, I'm taking care of the inpatient team. We had a person down there, 119 was their sodium, so very low. And we got to work on slowly bringing that back up. But we care a lot about sodium, has a lot of impact on the body. Next, we talk about potassium, which is essential for heart and muscle function. Normal range is about 3.5 to 5.0. And once again, both hypo or hyper can be a problem and can lead to cardiac arrhythmias or abnormal heart rhythms. So that's why we care about our potassium. Moving on to our chloride. Chloride kind of helps maintain fluid and is part of our acid-base balance. And acid-base is just essentially your body should maintain a very tight pH. So the pH is how acidic or basic your blood is. And your body's very good at measuring that and adjusting accordingly and appropriately to maintain a very narrow range. And chloride plays a role in that as well. So the normal range is about 96 to 106. It's often looked at in conjunction with sodium in maintaining osmotic pressure and for acid-base balance, like I mentioned. Very seldomly used in isolation. Like all the time, you will see slightly abnormal chlorides, and you go, okay, cool, that's great. That's why you look at the bigger picture of things. Very rarely someone look at it isolated, saying, what is that looking at? Next, moving on to the carbon dioxide. It showed carbon dioxide / bicarbonate. Those are kind of used interchangeably. And this is, once again, something involved in the pH balance. Normal is about 22 to 28. And it's a key component of buffering. Kind of your body uses, long story short, your body uses carbon dioxide or CO2. And then these kind of, you have acid and bases in there, bicarbonate and carbon dioxide. Those, you use those two where carbon dioxide is typically more acidic, bicarbonate is more basic, and your body kind of fluctuates those things by either breathing faster or hanging on to more bicarbonate. You kind of get, you can balance your pH once again. And so we are looking at these in conjunction with everything. It's kind of that buffering system. And so overall, those are the general components of the BMP. Not too crazy, not a whole lot, but there's enough where it's kind of confusing. There's quite a few things. And so next I want to move on to how to interpret the BMP results. So normal ranges, as I mentioned before, the specific reference ranges are highly variable between laboratories. And keep in mind that these ranges might differ based on things like age, sex, health conditions, underlying medical conditions, and it's once again reinforcing the importance of personalized interpretation by a healthcare provider. I'm not your doctor. This is not me saying advice or what you should do, but just understanding there. And when we have deviations, we can definitely have problems, or if we are not in that reference range, and reference range can be arbitrary, but if we're way off, we can lead to issues. Like glucose, for example, if we're very high or low, very high levels may indicate diabetes, while low levels could suggest hypoglycemia, which can be dangerous, and honestly maybe more dangerous than diabetes in the short term. So that's why we care about that a lot. Abnormal calcium is an issue. High calcium could indicate potentially parahypothyroidism, where low levels might indicate something like a vitamin D deficiency or magnesium deficiency. And these are much more nuanced conversations. Calcium is not just like, oh, that's a very normal, easy one. There's a whole lot going on there. Once we start talking about thyroid, parathyroid, all that stuff, it gets very complicated. It's more nuanced, but just worth noting that abnormal calcium also can affect cardiac arrhythmias as well. And so we want to stabilize. We take extra calcium to kind of, quote, stabilize the membrane to make sure we have solid electricity conducting through our heart cells. But once again, 20,000 foot view, calcium important for that. Next, talking about electrolyte imbalances, sodium. We care about this a lot. As I mentioned before, hyponatremia, going too low, or hyper, both are not good. We don't like that. When we're hypernatremic, we tend to think that, hey, we've lost free water. Because in our body, if we think about it, the blood specifically, we have a mix of water and solutes, and specifically sodium is one of them. And if you lose actual water, then you're left with just the sodium in there, so it seems higher. So you have a hypernatremia, so that's dehydration or water loss. And then hypo is when we're having low sodium. That can be kind of essentially, if you think about it, like diluted out. If you've diluted out your sodium by things like heart failure, kidney disease, what's called SIADH is kind of another symptom. You're holding on water. And so when you have too much fluid in your blood, essentially it's diluting out the sodium. So that's what we call hyponatremia. And that's a very simplified version. These are literally like days of lectures in medical school, but it's important to know that it's very, very important for the balance of the cells, for the oncotic pressures, things going in and out of your bloodstream, all that stuff. So we care a lot about it, because if it's not corrected in a timely fashion, you can have lots of neurologic issues in terms of like worry about comas, or if you correct it too fast, stroke. So if your sodium is drastically off, please do not manage that on your own. Please seek help on that. Next, moving on to potassium. Potassium, we can have hyperkalemia, hypokalemia, and both of these can lead to fatal arrhythmia. So we care a lot about potassium when we're talking about the heart. Chloride, like we mentioned before, important in acid-base balance. An abnormality usually isn't indicative of an overall acid-base disturbance. Like if you say, oh no, like my chloride's off, my acid base is off. No, that's a whole different thing. We talk about pH and VBGs and labs that we don't talk about here. But if you are elevated to hyperchloremia, have elevated chloride, a lot of times it's a sign of dehydration potentially. It could be things from like GI loss or kidney disease as well. And if you're low, sometimes it can also be from diarrhea or vomiting as well. And once again, these are always taken in context of everything. So I'm not just saying, look at a number. That's kind of what we're looking at there. Next, moving on to BUN and creatinine. And if you have an elevated BUN and creatinine, that may suggest that we're having some impaired kidney function or potentially dehydration. If it's elevated, we do think, could there be a problem with the actual kidney itself? Do we have an acute kidney injury? Was there decreased blood flow there from like shock or dehydration? Did we have a GI bleed? Or sometimes you can also just, when you have elevated BUN, you can have a really high protein diet or creatinine, because creatinine is a breakdown product of protein, and BUN essentially is as well. And so if you have a high protein diet, you may have an elevated BUN or creatinine. We'll talk about that more in a little bit there. And if you have a low creatinine or BUN, sometimes you can say either like overhydration is an idea, not that common, but a lot of times if you're very low creatinine, it's kind of talking about malnutrition or you're under muscled. So if you have no muscle, then your creatinine is very low. So sometimes we'll see, little old ladies in the hospital and their creatinine is like 0.3, and we're like, oh, their kidneys must be so good. It's like, well, that's not necessarily the case. It's just that they have no muscle mass really, and so their numbers are lower. And so that's kind of the general, just once again, 20,000 foot overview of when we have these things, how are we kind of interpreting them and what abnormal ones can go. And next, I want to talk about factors that affect BMP results. And so diet is always important. We think about that. High sodium diets can shockingly lead to high sodium, but it's not that easy, right? It's not like your body's very, very, very good at maintaining its proper balance of things. I'm just going to throw that out there. So if you intake more sodium, most likely what you're going to do is your body's going to adjust, maybe add in additional water. They say, if you drink, or consume sodium, you hold on water more, you gain weight. That's probably what your body's going to do more than rather just get a higher sodium number. So it's very, very intuitive, but it can happen. Additionally, potassium, diets low in potassium can lead to, shockingly, lower potassium levels. And so it's deficient in all the things. And once again, that's not very common to see people who are hypokalemic just from their diet alone. A lot of times it's from medication wise. And as we mentioned before, diet can affect glucose, whether from a diabetes perspective, if you're eating a high carbohydrate meal, that can happen. So diet, that's much more nuanced. I didn't want to open the can of worms on all those things, but just understanding you can make some differences there. But once again, your body is very intuitive and can usually fix it for you. Moving on to exercise. Exercise definitely can affect things. Acute exercise can certainly change values. Specifically, I'm going to kind of walk through what the general trend is. So if you exercise, your sodium could increase or decrease depending on how much you sweat or anything like that. Potassium maybe changes a little bit, most likely increases. Glucose could be either. Usually acutely during exercise, though, your glucose goes up, whereas after it might go down a little bit. Creatinine, BUN most likely increases. Your GFR may decrease with that. Chloride, usually no real change. And then carbon dioxide or bicarb decreases. And so this is just acute exercise. So if you said, hey, I just got back from the lab, I was working out, and then you go to the lab to get some blood drawn, you may see some changes there. Just something to consider as well. Then there's medications. There are lots of medications. So many to include here because that is a pharmacology class. But some of the most common medications we have that cause electrolyte abnormalities are diuretics, most likely to affect these electrolytes. ACE inhibitors, which are like high blood pressure medications that ending in ill, like lisinopril. These may mess with your potassium. And then SSRIs, medications for anxiety, depression, can also affect sodium as well and have lots of other issues as well. And finally, hydration. Dehydration can lead to elevated BUN and creatinine levels, like we mentioned before. And so, yeah, the things you eat and the things you drink can play an impact on what is going on with your BMP. And now I want to specifically talk about our everyday athlete specific considerations here. So what I mean is like people who work out don't have to be elite athletes, but want to talk about what lab abnormalities we could see or expect in these people. So this is me in primary care as a sports doc. A lot of times this is, my passion. This is what I'm looking for. But if your primary care doctor may or may not understand these things, and that's not a knock to them. Like, I'm a nerd. I do additional research. I'm a sports medicine doctor. I have additional training. So these things are kind of my alley, but your general primary doc might not have this. So this is kind of the caveat to the athletes out there who are saying, hey, your blood results might be a little different, and here's why. So we'll dive into it here. First, for endurance running, this is more like in a race. Like if you are drinking so much water and just pounding it, and you might have something called hyponatremia, once again, too low sodium. This is usually the person who's never run a marathon before, and they're running a 4 to 5 hour marathon, stopping drinking water at every stop. That's not ideal and can lead to, like we talked before, neurologic issues. But usually we just treat with fluid restrictions and monitoring, and don't usually have to use something called hypertonic saline, which is like a really concentrated form of salt. And so we don't necessarily do that, but it can, if you drink too much water, it can mess you up. But for most people, that's more acutely, like if you're running a marathon, don't just drink to thirst. Don't just keep pounding water. That's like my biggest recommendation, but just something to keep a heads on. But usually just endurance training in general shouldn't lead to hyponatremia. It's only for over drinking. From an acute exercise perspective, we would expect to see a rise in creatinine due to using more muscles, right? So we're using more muscles, they're breaking down, so we're going to have more creatinine, and probably going to see an increase in BUN as well, and may see some other electrolyte abnormalities like we mentioned a little previously. Now I want to talk about well-muscled individuals. So people who are jacked, what's going on here? Well, if they have increased muscle or they're consuming lots of protein, increased protein intake leads to protein metabolism breakdown, and it produces urea or the BUN, and it'll show up as elevated BUN. So it doesn't mean that something's wrong necessarily, just that we have to explore more. So funny story, actually, I got labs from one of my doctors a couple of years ago, and then she looked at me like, do you just eat a lot of protein? I'm like, yeah, I do. And so that's what happened. So if you have an elevated BUN, can be because of that. Once again, I'm not going to say, oh, that's it. That's no problem. My creatinine or BUN's elevated. It's because of that. No, we'll explain a little further here. And so now I want to dive right in and talk about the kidney considerations for athletes. And so as we talked about a little bit before, muscle mass and creatinine are related. So as one goes up, so the other. So if you have a higher muscle mass, so you're bigger, more jacked, you're probably going to have a higher creatinine value. And it's not uncommon to see someone who's well muscled to have a creatinine of 1.1 to 1.3 kind of in that area. That is not atypical. However, though, because of calculations, we know that GFR is based off of creatinine, right? So your filtration rate equation does take into consideration your creatinine. And if your creatinine is way high, then your GFR is actually probably going to be lower. And then it's going to look like, oh gosh, you got a low GFR, your kidneys are failing. Is it time to panic? This is the classic one that happens is someone who works out a lot, has a lot of muscle, comes to the doctor, right? Get the test, and they say, hey, your creatinine's high. I'm worried about your kidneys. What's going on? And everyone panics. So I'm going to kind of walk you through what we think about there. But real quick, I also want to talk about creatine supplementation. We know that taking creatine can increase creatinine levels. So creatine gets converted to creatinine in the body. So it will look like you have really high creatinine. Once again, that can be a scary thing when you're saying, hey, I have a high creatinine. That might indicate that my kidneys aren't working well. Well, what do we do? Well, now let's talk about some of the nuance behind that. One thing we can do is we can get something called a cystatin C. And a cystatin C is a protein in the body made by pretty much all your cells. And it's freely filtered in the kidney. Freely filtered means it just kind of goes through. We should understand that. It doesn't get absorbed necessarily as much. And it's not affected by muscle mass or creatine intake. So not affected by muscle mass or creatine intake. So we can use a calculator, a slightly different calculator that uses cystatin C instead of creatinine to estimate our GFR. So once again, we are using cystatin C to then calculate our glomerular filtration rate or marker of our kidney function instead of creatinine number. So that's kind of helpful. We're going to kind of take out creatinine so that we can see, hey, is it actually because the creatinine is elevated and because we're, having a lot of muscle or we're taking creatine or have a lot of, protein intake? That's one thing we can think about. And then we use the cystatin C kind of in place of that. It's not perfect though, can still be affected by things like steroids, how much fat tissue you have, inflammation, and thyroid dysfunction. However, though, If your GFR is low and you're a very fit person or you're pretty jacked, it may be worth looking into getting a cystatin C. And once again, this is not formal medical advice, but I have seen this quite frequently where we freak out. They get a referral to the nephrologist because they say, you go to the kidney doctor. You go to the kidney doctor, they do a cystatin C, and they're like, oh, you're good. Don't worry about it. And so that's just something we have to think about. And this is kind of my framework. I want to say, what do you do, if you're one of those people whose labs are normal? First, don't panic. For me, typically, unless I have an enormously life-threatening situation lab, I'm not, you're not going to send you to the ER. A lot of times we'll say, hey, this is a little up. Let's take a look. Let's repeat those labs. And so it's very common to see lab errors with some of the BMPs. And even then specifically, I'll see potassium things that, a little up there, 5.3. I'm like, I'm not sure if I believe that. And then recheck it. It's normal. And so a lot of times we recheck lab. That's my general rule of thumb is if you don't like it, recheck it because you want to verify it. And then also evaluate whether, you set yourself up for success or not for that lab draw. So were you adequately hydrated? Were you dehydrated? That might affect things. Did you recently work out? As we mentioned, a workout might affect some of those numbers. Are you taking a creatine supplement? That's also good to know. If you are, then I'd probably say, hey, let's stay off creatine for a couple of days before getting a lab test. I think that's probably a reasonable idea. I think if you're going to go get that measured, taking a few days off of your creatine supplement is not going to ruin your gains. I promise you that. I promise you can take some time off and then start back up after you get the labs. We can kind of help you get a more neutral look at things. And then if anything's off that day, then repeat the labs, right? It might be worth to repeat it as well with a cystatin C. So if you're saying, hey, I did work out, I didn't really drink as much as I wanted to. So cool, let's repeat those. And then maybe on top of that, if you're already fit and you think you have a decent amount of muscle, then it may be worth to get the cystatin C as well. And then you take a look at those, reevaluate, and then you can kind of have the next round of labs if you need to get it again or need to get further things there. So I want to say, a lot of times don't jump to conclusions that your kidneys are dying. A lot of times that's the thing I see online is that, oh my gosh, my doctor sent me to the nephrologist, the kidney doctor, because my kidneys are dying and I shouldn't eat protein and protein's bad for my kidneys. And as you can see, it's a lot more nuanced to that. And there are other ways to look at it. So I definitely don't want to say, what I don't want to say is, oh, my creatinine's elevated. It's not a big deal. I got a lot of muscle. Like my creatine is like 1.5, no big deal. Like, no, that's not what I'm saying. Upper limit normal is like 1.2, 1.3. Once you start creeping up into 1.5, I don't know if there's a level of jackness that would get you up to that high. So I definitely don't want you to be like, whatever, I'm good. But it's a consideration that if it's high, then maybe check those other things. And so overall, I think the BMP is one of the most common labs we're going to get. And we're going to see it everywhere if you get it. It's commonly affected by lifestyle changes, specifically exercise can happen. Creatinine and GFR aren't perfect, as we learned. And if you're well-muscled, you may have some abnormalities that require further workup, things like getting a cystatin C. And so that's kind of the takeaway here is that your BMP, looking at your electrolytes, looking at your sugar, looking at your calcium, looking at your kidney function, that's like the general gist of that. And it can be affected by exercising. And so I just want to mention that. And so that's going to do it for today. Thank you so much for stopping by. I really appreciate it. If you found today's episode helpful, and it would mean the world to me if you left a 5-star review on your podcast platform of choice, or if you share it with a friend who might enjoy it. And if you want to, never miss any of the content, please consider signing up for my mailing list, which is linked in the description below. I'll send out content as I release it during the week, but I promise I'll never spam you because I hate spam. So that's it for today. Thanks so much. Now get off your phone, go be active, have a great rest of your day. We'll see you next time.